Hello, my name is Bart Scott. I'm an expert in the management of myelodysplastic syndrome, or MDS. I see patients in my clinic, and I also run the clinical trials program for MDS at the Fred Hutchinson Cancer Research Center. And I've been asked to speak to you today about some of the common questions that come up when I'm discussing cases with physicians. And one of the questions that's frequently raised is, what is the most appropriate treatment for patients? How do they compare? And when should they be given in a particular patient? And there are 3 FDA-approved drugs to treat MDS currently. That is 5-azacitidine, known as Vidaza, decitabine, known as Dacogen, and lenalidomide, known as Revlimid. And one of the important things that we do as physicians is that we first assess risk, because that would determine what the most appropriate treatment is. And the risk would be assessed by the revised IPSS criteria, which was published in Blood in 2012. And it's based on several factors, and these are their blood counts, the underlying cytogenetics, and the bone marrow blast percentage. You basically add up these different risk factors, and you can calculate what the IPSS score is. For patients who have low or intermediate 1-risk disease with deletion 5q and who are red cell transfusion dependent, with the other counts being normal, lenalidomide would be the drug of choice. It has been shown in both a phase 2 and phase 3 randomized trial to result in a transfusion independence rate of approximately 70%. The major limitations of lenalidomide are thrombocytopenia with lowering of the platelet counts. This is generally seen in the first 8 weeks. Lenalidomide is given as a pill. 10 milligrams daily is the recommended starting dose for most patients. It is cleared through the kidneys, so there may be dose adjustments needed for underlying renal insufficiency. Then with azacitidine and decitabine, these are both hypomethylating agents. We believe that they work in a similar way. Azacitidine can be given either IV or subcutaneous. Decitabine would need to be given IV. Both of these agents have been studied in phase 3 randomized trials for patients with higher risk disease. Azacitidine is FDA approved for low, intermediate 1, intermediate 2, and high risk disease, whereas decitabine is FDA approved for intermediate 1, intermediate 2, and high-risk disease. In a phase 3 randomized trial, azacitidine was shown to improve overall survival compared to conventional care regimens. Decitabine, on the other hand, failed to show an improvement in overall survival compared to best supportive care. Now, there are many reasons why there may have been a difference in regards to the findings of these clinical trials. The decitabine may have been stopped too soon. There may have been different populations between the 2 studies. There were differences in the way the drug was given, and there may be, honestly, a true difference between azacitidine and decitabine. Based on the available studies, it's my general preference to treat patients with azacitidine, and that's because, as I said, azacitidine was shown to prolong overall survival. The recommended dosing of azacitidine is 75 milligrams per meter squared, given daily for 7 days in a row on a monthly basis. Azacitidine can either be given subcutaneously or as an IV infusion. Decitabine is given IV. It can be given at a dose of 20 milligrams per meter squared daily for 5 consecutive days. With that, I will thank you for your attention. I'd be happy to take any other questions you may have. Thank you.